Thank you so much, Jeff. And yes, I'm gonna ask a few questions of the panel. I know there's a lot of questions already in the Q&A, so I will also make sure I leave plenty of time for that. But I actually wanted to start, first of all, thank you so much. You all spoke to just different aspects of this problem, and I think you just covered such a wide amount of information, and from the personal, from the professional, how you think about these things, how like your development in terms of your thinking. I wanted to start asking Dave and Howard, as medical professionals, because I'm imagining that perhaps not now, given that you're sort of known for this work, but I'm imagining, earlier in your careers, people would really come to you looking for medical explanations, medical treatments. And I'm curious as to what your experience has been in trying to suggest to people or educate them about potential emotional or psychological factors. I'm wondering how open people are to that, or ways that you've developed to talk to people about this potential that can, be received as well as possible. And I will let either of you jump in.
Go ahead, Dave.
Yeah, it's a great question. People find it difficult to believe just how ill you can get from stress, just how much pain you can be under. One of my patients was a 17-year-old girl I was asked to see for unexplained abdominal pain. I was GI consultant number 7. She'd been in the hospital for 10 weeks. She was getting 250 milligrams of morphine around the clock for this unexplained abdominal pain, where 5 or 10 milligrams of morphine would be enough for a fractured femur. And so the level of symptoms you can get from psychological distress is every bit as severe as any other form of illness. But people find it difficult to believe that, so I have to persuade them that this is on the list of possible causes. And I found it's most useful if you bring this up right at the beginning. So when a patient is seeing me for the first time and I don't really know for sure what's causing their symptom, I can say, well, you might have gallstones, you might have an ulcer, or you might have stress going on. Let's investigate all 3. And this is much better accepted by people, especially when they hear, that how severe symptoms can be from stress. And then we can go from there. We can do diagnostic tests looking for the biomedical causes, and we can start talking about stresses in their life, past and present, and see where that takes us. And that usually is well accepted. Howard?
You're walking a fine line, because people who have been traumatized often feel hurt and have, as Dave mentioned, have low sense of themselves, don't feel worthy, feel invalidated. And then they get illnesses, and then they get more invalidated by people who telling them that it's all in their head and they're not really sick. And their family members telling them that it's all in their head and they're not really sick, because the doctors can't find anything wrong. And sometimes people their disease becomes their identity in a sense, because they find others, like-minded others online who have fibromyalgia or EDS or you name it, long COVID, et cetera, chronic Lyme disease. And then that becomes their validation. And so to invalidate people is the last thing you want to do. On the other hand, but when you validate them, saying, yes, this is real, this is severe, this is a problem, but then the medical viewpoint, yes, and it's incurable, so there's no hope for recovery. So we're trying to tell people it's not in your head, but it's in your brain. That's a big reach for a lot of people. That's a hard thing to get across. And because you say it's not in your head and it's in your brain, and then they go, yeah, you're saying it's in my head. And it's sometimes just really hard. And some people just are not going to get that. It goes counterintuitive to everything we know in society, everything medicine tells people. So the only thing that I can say that I always try to do when I advise people to do is use this 4-letter word, which is often not used in medicine, which is love. And I just try to love people and be compassionate for them and listen to them. Because if they don't think you love them, how are they going to listen to you? And so to me, it just starts with that. And then we look at the evidence and we try to see what makes sense. And, we just go from there.
Can I answer that?
Of course.
Also, what I have found, because it is tough. I mean, first of all, not everyone comes to me seeking pain relief. I get other patients, but they have pain, and then I have to make the pitch. What I find is if I recommend a book to read or videos to watch, it takes some of the dynamic of I'm trying to convince them of anything. And they can look at it or read it in their own time, in their own privacy. And I think it reduces people's resistance, defensiveness. And they tend to, I've heard many people say, especially about Dr. Sarno's books, I saw myself on every page. And sometimes that they then come back and are more open to it.
Thank you. Fran, yeah. Oh, sorry. I just unmute yourself if you would.
I would like to echo that, Jeff. As I mentioned earlier, education is so important, and for the patient to go away and read and see if they can, it makes sense to them. I find that that's very, very important.
Thank you. I want to go straight to the, first of all, I see either mango or papaya behind you. I want to go straight into the Q&A because we actually have a lot of questions. Ted Borer is hoping someone will speak to meditation or hypnosis in addressing physical issues. Is this meditation or hypnosis? Is that a part of any of the approaches that any of the panelists use? Do you see a role for that in your work? Fran, yeah.
Absolutely.
Mm-hmm.
One of the most common forms of meditation that I work with often right at the beginning is a simple breathing practice. Because when we focus on our breathing to help us regulate autonomic nervous system activation, we're doing a kind of meditation. And when people start to feel the positive impact of that, lowers their fear, they feel empowered, and then we can talk about the things that are going on in their life, and we can talk about their pain and from a different perspective.
I've been a mindfulness meditation teacher since 1999, and it's revolutionary, helped me in many, many ways. I think everyone should learn mindfulness, children, everyone. And when you look at the research on mindfulness for pain reduction, it is not very impressive. And so how do we reconcile this amazing technique, and yet the effects in research studies on chronic pain is quite small, no better than CBT, and the effects wane over time. And people hate when I say this because it sounds heretical, but it's true. And the reason is, I believe, and we do use mindfulness techniques a lot in our practice, but first we're recategorizing the problem. If you're using mindfulness to treat pain, and you presume, as most people would, the pain is due to a structural problem, you can notice the pain, and it's your body's damaged, and you're incurable, and then maybe you can mute it some degree, but it's not going to go away. But if you recategorize the pain as an emotion, if you recategorize the pain as a sensation that is not damaging, that is brain driven, is created by the brain, and then you pay attention to it. It's like paying attention to a thought in a sense. And now mindfulness can have incredibly powerful techniques in actually reversing these chronic painful conditions, as opposed to merely coping with them.
Thank you. I want to move to the next question, and just a couple people have put amazing questions in the chat. I'm just going to ask you to copy and paste it and put it into the Q&A if you don't mind, so I don't lose it. We have a question from Nina Guten, and Jerry, I think this really speaks to what you were talking about, and maybe you can speak more to this. Nina's asking, can you speak about how to work with those from cultures where somatic symptoms are normative idioms of distress? and where talking about issues or conflicts is frowned upon and prohibitive. So how is the best way to work with people who may be coming from a culture, as I hear Nina asking, where somatic symptoms could be a very common way that someone's suffering is expressed, and that talking about things might be more prohibitive? Can I toss that to you first, Jerry?
Sure, yeah. So great question. I think from my perspective, if kind of getting too close to the issue causes even more resistance, it could just be taking a step back. And what I will do with people is just say, well, where do you feel it in your body? And the times that you do feel it, what else is going on? So that there can be connection in the present that maybe feels safer than the other, like, more traumatic or difficult issues. And if they're coming to you, then there's opportunity to build trust, and then hopefully in time that cultural barrier would go down, and with the increase in trust, that's what first comes to mind for me with that.
Thank you. Yeah, this is anyone else, actually, before I move on? Any thoughts on this working, perhaps, with patients who might have an experience of a particular symptom? I mean, one of the things that I learned that I didn't know in researching this panel is how culture-bound specific manifestations of pain are. I think, Jeff, I got that from a webinar I heard you do about how, that in particular areas within certain cultural contexts, people might experience pain in certain part of their bodies. Someone is also asking in the chat, Jim Greenberg asking, do any of you address chronic pain by addressing the trauma of living in a culture of white supremacy? And if so, how do you address with your patients? So I think Jim is asking here, is systemic racism potentially a stressor that could be related to chronic pain? Yeah,
I've just been working with a group of 8 other, I don't know if other scholars, but 8 scholars, not sure I include me, but 8 scholars to write a paper on racism as a source of pain. And we submitted it. I think it's going to be published soon. And it was really an amazing process to get all the input from all the different folks who worked on it together. And there hurts cause the brain to react, as we said. And so in order for people to understand this, we have to understand that a lot of the hurts that occur are societal hurts. And there's a study by Tim Brown where he showed that something, I forget the actual number, but he's a public health person, but he found that some 40,000 or something people have pain because of racial discrimination. And amazing study. I can get the reference for folks, but however people are traumatized, that's that happen. Those things happen. I mean, it's just part of the world we live in. I have a young friend who's Canadian who was living in the Bay Area for several years, and she started getting headaches, stomach pain, back pain, all sorts of symptoms. Finally, she moved back to Canada, and her symptoms all went away. The United States can be a toxic environment in so many ways, and if you're a person who's marginalized, that's just adds on to that.
Thank you.
One of the fundamental issues in psychophysiologic disorder patients has to do with their self-esteem, which may be wounded in childhood by their dysfunctional environment, but it can also be wounded by society if you are treated with less than your full humanity because of your skin color, your ethnicity, your religion, your LGBTQ status, whether you're neurotypical or not, whether you're disabled or not, all of those factors contribute to that wounding of the self-esteem. I think it's also important to recognize, as Jerry pointed out, that the psychology profession is largely white. A PhD psychologist, 86% white was the last figure that I saw. And It can be enlightening as a straight white male person doing psychological work. If I'm with someone who is not in that category, to ask them if there's something about this characteristic of myself that could be limiting to them or could cause them concern. And you can have some fairly enlightening discussions following that question.
Thank
There's an
you.
incredible epidemiological sort of fact. If you look at the graph of the incidence of chronic pain, it's like an epidemic and it goes up. And if you overlay on that graph, on that line, the increase in income gap and wealth gap, it's almost exactly the same. And so I think people are really pissed off. And I guess in my work, I'm often looking for anger and people who are suffering with structural racism are justifiably and understandably angry. And I help them to find that. And just to go back to the other question about culture, what I find I do is I ask people to educate me about their culture and how pain is helped, and then I'm learning also.
Thank you so much. The Q&A is actually on fire, so I want to make sure we get to all the many questions being asked. Fran, can I ask you to speak to this next one? This is a question really close to my heart. Lisa Robin is asking, how does a psychoanalyst who is part of a, let's say, conservative professional community talk about integrating these measures, breath work, let's say? I've heard derisive comments about even just suggesting a patient learn breathing exercises. Have you experienced resistance, Fran, to integration or some of the other things you've spoken about? I know somatic experiencing, and from the psychoanalytic community, what have you found in that regard?
When I started analytic training, I in 1989, I did not dare tell anybody I was going for body work. It was really verboten. And right at that time, the relational school of psychoanalysis was developing. And the relational school of psychoanalysis is a completely different model of understanding how we help people and what happens in the process of treatment, and what the flexibility of the psychoanalytic frame is much greater than in a more traditional classical analytic frame. So I was also able to use the work of a very classical, highly respected psychoanalyst, the late Henry Crystal, who worked with people with addictions and physical symptoms and Holocaust survivors. And he actually used biofeedback for some of his patients. So I could always refer to his work as a kind of anchor from the world of classical psychoanalysis to incorporate and justify what I was doing with patients. And as the world of relational psychoanalysis expanded, it's open to a wide range of inputs. So I'm very happy to have been present when it started, and it's helped me enormously justify and be respected for the work that I do.
Thank you. We have, let's see, this is related to something you spoke about, Jerry. Albert is asking, can you comment on the fact that the psychotherapeutic approach to connect pain and emotion is highly time and labor intensive? Most patients cannot find a therapist. So I guess speaking to the difficulties with accessing care, what alternatives are out there?
Yeah, it is time intensive and labor intensive and emotionally intensive. And even connecting when I think, Bevan, you actually said a lot of people, their first sort of way of getting in is with a primary. And with the work I do, there's so many people don't have a primary care doctor, right? So it's like, how are they getting connected at all? There's certain groups have, like, I don't want to say, there's different, like, for example, in New Jersey, in Mercer County, where I live, there's a organization called Women's Space, and they will work with people on a sliding scale. There's a lot of therapists who will work with people on a sliding scale. And I don't know that I would have known that if I hadn't had my experience. So it is time intensive. And for some of us, we have the privilege to be able to do that, and some don't. Talking to other people, which is also challenging. I think the more we talk in our social circles, that we make therapy or going to therapy normal, then you can say, well, who do you see and who do you talk to, or how do I get into it? Faith-based organizations are more getting to be more open. So just really connecting in your community and finding ways, if your workplace has EAP or employee assistance program, those are limited, but it can be a start. So just connecting as much as you can with people that you trust and organizations that you trust.
Thank you, Jerry. And I know, I know from watching This Might Hurt, Howard, in your approach, patients were actually speaking to peers, to other patients about their emotional distress. That we are getting a lot of questions about the approaches that you use psychotherapeutically. So if I can start with you, Jeff, this is sort of a big question from Daniel. Can you encapsulate the depth approach to separation issues that you referenced?
Well, first you have to identify it as an issue. A lot of people just see it as sort of normal, that their enmeshment with their whoever it is just the way it is. And so first, I think identifying it. And also, I think, as Dave was talking about the case, he talked about, noticing the correlations when the pain comes up and how it may be correlated with contact with the person that they're having difficulty separating with. And a lot of it has to do with developmental stage also. Teenagers, young adults, I will talk with them often about, like, your job at your stage right now is to start swimming away. I like this metaphor. My kids were on swim team for a while, and I would talk about, like, adolescence as the time for the flip turn, that, during childhood, you're swimming towards your parents, and then in adolescence, you gotta kick off and start swimming away. And if you talk to people, what do you feel like you want to do in your life? And they will be able to say, well, I'd like to have a partner. I'd like to live on my own. Well, let's talk about that. Why is that hard? Is it hard for you to separate? Is it hard for your parent to let you go? That's, and then, sometimes we go back to, attachments, and whether it's a secure attachment or a disorganized attachment, et cetera, and go back, earlier as well.
Thank you, Jeff. Howard, we have a question directed to you from Carol Paxson. How do you process trauma that was too early to be remembered consciously? So does that occur in your work? Do you?
Well, I do a lot of kind of trauma processing work for.
Uh-oh.
Oh, I think Howard might have froze.
Yeah.
Okay, I'm a little relieved it wasn't me. Okay, so we're going to hold on to that thought. Hopefully Howard is going to rejoin us. Oh, Howard, sorry, you cut out for a second. Okay, you're back.
Yeah, I let people choose what traumas to process. I think that if they process even the smallest thing that happened yesterday, or something that's happening in the room with us, or something that happened last week, it's part of processing all of the trauma, I think. And so I leave it up to them, number one. And then I help.
Oh dear.
Oh no.
Okay. All right. So
Let's just look at that fear in your body. Are you missing me?
Yes, sorry. I think your connection went out again, Howard.
Oh, okay. Should I keep going or stop?
Yeah, why don't you try one more time
try
and
one
we'll
more
fingers
time.
crossed.
And as soon as she got in touch with just the feeling of anxiety, she had an image of a little girl. So that's where we went. That's where we went. You can ask the anxiety, when did you start? Where did you come from? One of the most, I've had people go back to times when they were being birthed, but it wasn't me directing that. It was just them coming up with it. Did they have conscious memories of it? I doubted it, but that's where they went. And one of the most poignant moments I had was with a guy who went back to visualize his father when his father was a child. He had a rageaholic father. And when his father was a child, his father was neglected and abused. And he went back in time to visit his father. It was really poignant. It helped him develop compassion for his father when before he mainly had anger toward him. It's a very healing time. So this idea of time traveler, on my website, if people are interested, there's a meditation called Time Traveler they can access. And it's just, a little simple process of helping people go back in time to heal hurts.
You can work with dreams as a way to get to very early thing. And I think what Jerry said about where do you feel the pain in your body can be very powerful.
Many of my patients have a tendency to minimize the amount of trauma or dysfunction that they experienced as children. You'll hear them say things like, it wasn't that bad, or I've overcome it, or other people have been through worse than I have and they seem to be fine. And a technique that's been very helpful for those patients is I ask them to imagine themselves a butterfly on the wall of their childhood home while they watch a child they care about, either their own or someone else's, try to cope with that same childhood environment that they had to deal with, and experiences that they can look at in their own life and not get too emotional about. If they start thinking about it happening to their own child, it's a completely different situation. You'll see their facial expression change, and they'll be able to connect much better with some of the repressed emotions that they have around those experiences.
Thank you. I have another question, and I think this is one that might be on many people's mind. I know our PsiAN's membership tends to run heavily psychodynamic, psychoanalytic. So we have an anonymous attendee asking, what are the clinical strategies for pain treatment? So the pain treatments you are all discussing, and how are they different from psychodynamic approaches? My sense is you're all touching on education as being an important component of it, but I also wanted to let you speak to what you understand to be difference of just sort of a general depth therapy approach to working with a patient and the work that you do with pain and somatic issues. Fran, yeah.
I'll say a few things about that. One of the things that's different is I'm always keeping the body in the room when we're talking about whatever we're talking about. So, and I let people know, people who come for treatment of pain, I let them know that that is part of how I work. And I say, from time to time, I'm going to be asking you, how do you feel emotionally about what you're talking about? And what are you feeling in your body? So I see my goal is helping reweave the connection between the mind and the body and emotions. And we can throw the spirit in there as well. So it's an active attempt on my part to include the body and to include emotions very directly.
Thank you. Yes. Anyone else have a thought on this? How your approach might differ from just sort of a general depth therapeutic approach?
I tend to take an educational approach. I want patients to understand the stress-inducing personality traits they have by, for example, recognizing what they learned about themselves as children that isn't true. If they learned that they were second-rate human beings, if they learned that their boundaries of their body didn't need to be respected, if they learned that it was their job in life to take care of everybody else, but not to worry about their own needs. By learning how they were taught these things, by learning how these fundamental assumptions about themselves were implanted in an unhealthy environment, it facilitates effecting change with respect to those things. Similarly, they can learn why certain people, situations, or events in the present day can be so triggering because of links to the past. If we can understand those links, if people can learn why those links exist, it facilitates changing them and reducing their impact and setting boundaries.
And after education and understanding it all, there are very specific, simple pain reprocessing techniques that we've been using. And that's what we used in the Boulder back pain study and in the Harvard study, where we were helping people do the simple things of changing their relationship to the symptom, stopping the fear of the symptom, stopping focus on it, stopping being frustrated by it, starting to approach the symptom with interest and curiosity, approaching the symptom with feeling safe, reassuring their brain. These are all very simple techniques, but very different than psychodynamic techniques. And they're all outlined in the books that we put in the chat and the training opportunities that I also put in the chat and in our research studies, which I'll link those studies to you as well.
So just as a, oh, sorry, go ahead, Jeff, please.
Just one difference I notice in myself is that I tend to be more willing to self disclose in terms of my own struggle or my own recovery from chronic pain, which is, you know, verboten in psychoanalytic work usually, you know. Anyway, I just find myself being more willing to do that, and people seem to really appreciate that, and it helps them to destigmatize it for themselves. If I'm vulnerable about it and admit, you know, what I went through, then that sort of opens them up.
Thank you. Well, I know I'm kind of running through these quickly. I want to make sure I get to as many as possible. So we have another anonymous question, is a very interesting one. If presumably psychogenic pain begins to manifest after someone has made therapeutic progress, what are we as clinicians to make of this? Does this suggest that we are wrong about making progress with a patient? Is it likely symptom substitution? Is that a common finding that you have, that if depression or anxiety is successfully treated, then pain could manifest? Or Howard, I see you nodding. What have others found?
Yeah, it's
Jet?
super common.
Yeah.
Super common.
Okay.
Happens all the time. That's how I learned that pain and anxiety and depression and these other symptoms were all similarly derived, because they were interchangeable. One would come and the other one would go. And if the danger alarm signal is still going on, the brain is going to create some other manifestation. Symptom substitution is real. We see it all the time. And, you know, it's just, I think it's a matter of being patient and keeping working through the issues and helping people see that their brain is being creative and still sending them messages. And maybe there's something they need to change in their life or some other thing that they need to do. But you know, there's ups and downs along the road to recovery.
I would say, as someone who experiences it, I mean, the list that I went through, like it's one thing came and then it left, and then, you know, and yes, it's frustrating and all of that. And it's like it's almost a reminder of, oh, I need to take care of myself. Oh, when I feel this way, that means that there's something else going on. And so I can say that I'm able to recognize sooner, like that I need to be paying attention, and this is a message that my body's telling me. And yes, it's frustrating and I hate it. And it's an opportunity when I can get a little bit distance from the frustration of it. So, I mean, that's like layperson just saying, responding to that of, this is the experience and it's not surprising from my perspective.
Thank you, Jerry. Fran, did you want to speak to that as well?
Dr. Sarno called this the symptom imperative.
Right.
And I encountered a lot. And also a lot of people who I see with a PPD symptom are perfectionists, and they are used to achieving at a very high level. and they want to be able to do the same in getting rid of their pain. And they want it to go away permanently. And if it appears in another part of their body or it returns, they can, in the beginning, start to feel like they're a failure. And so we work with that and try to think of it as a message from their body. And what is it telling me?
I learned from Howard, actually, a great reframe, which is, you've got it on the run. And Alan Gordon, the originator of pain reprocessing therapy, gave me another metaphor. If people have seen the movie The Truman Project, at the way end, when he's on the boat and the producers of his world are trying to get him to go back, he screams at them, "Is that all you've got?" And I help patients sort of say to their body or their unconscious, "Is that all you've got? You're going to give me another thing? Well, to hell with that. I've got you on the run." So I love that.
That's great. We have a very astute question no one can possibly answer in 1 minute, but I'm going to throw it out there anyway. Josh LaRosa is asking, first, thank you for wonderful remarks. Does trauma always have a manifestation as physical symptoms, or is it only in some cases? Individuals with trauma have correlative physical symptoms, and if it's the latter, is there any speculation as to why? So why do some people's trauma manifest as physical symptoms and others potentially do not? Anyone want to take a stab at a very brief answer to that?
Yeah, a variation on that is, that some people with similar experiences will get gastrointestinal symptoms and other people will get migraines. I don't have an answer to that.
I mean, obviously, sometimes the symptom is symbolic. It's a metaphor. You have pain in your neck, and someone's a pain in your neck in your life. You have stomach pain because something makes you sick. You have foot pain because you can't stand something. But not all trauma leads to symptoms. Many people have had trauma, but have had very resilient people in their life, loving people in their life, aside from the trauma. The trauma may not manifest for many years later. And people can grow from trauma. And I think that's kind of what we're trying to help people do, is take post-traumatic stress disorder and turn it into post-traumatic growth, help people grow from their experiences, because they can become better for it. They can become wiser, they can become more assertive, they can be stronger, they can deal with the issues in ways that help them connect to people and be more empathic and be more compassionate to themselves. So there's a lot of tremendous potential for growth within this work.
Yeah, Jerry was making that point earlier, that you use your symptoms as a opportunity for learning more about yourself.
Thank you. And I'm seeing it's 8:31. We still have so many more questions. I wish we could keep going. I just want to thank the panelists so much. This was obviously a very stimulating talk, got a lot of thinking and discussion happening. For everyone attending, just so you know, we definitely will be compiling these resources and some others about trainings, about readings, and we'll be sending them to all the registrants. And I just want to thank all the panelists for coming tonight. And it was a really wonderful evening. Thank you for everyone attending. And we will say goodnight to our attendees.